Dr. Hussam, could you please?
I am honored to present our second speaker, Dr. Yahya Alqahtani. He is an orthopedic spine surgeon. He graduated from France and he did fellowship there, then another fellowship in Canada. He has special interest in deformity. Yahya, you can start, please.
Thank you very much for the invitation and thank you very much for the introduction. Thank you, Dr. Daniel, for this topic. My presentation will be more of a basic presentation, as I did it directed mostly to the resident, with some emphasis in some surgical points. So to go through this will be basic anatomy and then some surgical points. Thoracic spine is part of the spine. It's less complicated than what we see in the cervical, and as we go down to the lumbar area, it gets more or less complicated. It participates in the shape of the spine with the sagittal and the sagittal plane, with the normal kyphosis averaged from 35 degrees, average 35 degrees, and normal range is from 20 to 50. In the bone itself, the vertebrae are heart-shaped, and the vertebral body side increases progressively from T1 to T12 as it bears more weight of the trunk. The spinal canal dimension is also varies from T1 to T12. We can see in this diagram that it starts at T1, T2, and then it goes to smaller diameter and then goes back to the diameter where it goes bigger. And in T12, it's almost like a lumbar lumbar canal. The facet joint orientation also is different in this area. So these are the typical vertebrae from T2 to T8. We can see here, this is the body and this is the posterior arch. The spinous processes are hanging all over each other. We have 7 facets, 2 in both body for the ribs and 1 in the transverse process also for the ribs, and 4 facets for the facet joint. The superior one are facing posteriorly and the inferior one are facing anteriorly. The advantage, the posterior arch is together they served as a protection for the spinal cord, attachment for muscle and ligaments, and articulate with the adjacent vertebrae. The atypical vertebra are the T1, where there is only 1 facet that articulate with the T1 rib. At T10, there is also 1 in the body and 1 in the transverse process, while in the T11 and T12, there is no facet in the transverse process. The orientation of the facets are mostly vertical, which allows a very little flexion, but allows more of rotation movement in the thoracic spine. The movement in general is less in the thoracic spine because of the attachment to the rib cage and the orientation of these facets. The stability of the spine are arranged by the anterior longitudinal ligament, posterior longitudinal ligament. The anterior longitudinal ligament is attached superiorly in the skull and extend to the anterior surface of the sacrum. And along its length, it's attached to the anterior body. The posterior longitudinal ligament lines anterior to the vertebral canal, and it's also attached to the posterior side and to the discs of the body. The ligamentum flavum is attached from one lamina to the other. And we can see clearly in this specimen that it attached from the anterior surface of the lamina above to the posterior surface of the lamina below, which help a lot when we do decompression to start at this point because we have the ligament protecting the spinal cord. Here is the ligament, interspinous ligament and supraspinous ligament. They are very important. We can see it also in this specimen. This is the supraspinous, and this is the interspinous ligament. They are very important in stability, and we can see in this MRI that there is injury in the posterior complex, and this necessitates fixation even if we don't see a lot of compression in the vertebra. The vertebral disc also maintain the stability of the thoracic spine with the nucleus pulposus at the middle, which is all we know about. The muscles, I will talk only about the paravertebral muscles. We can see here it's covered by the fascia. Here they are exposed, and we have three muscles that help extend the spine when we flex when we are in the flexion position. It helps to make you back to the extension. And we have also the deep layer, which are the rotators. We have short rotators and long rotators. The short rotators goes from goes from the vertebra, from the spinous process above to the transverse process below, while the long rotators, they go from one vertebra above to the transverse process in the vertebra itself. We have also the multifidus in this direction. All these muscles help to make the rotation movement of the thoracic spine. There is more ligaments that enables stability of the spine, which connect the transverse process to the ribs, and there is also ligaments in the rib heads that allow movement that allow the rib to rotate around their longitudinal axis, which occurs in the upper ribs, and the second descend relative to vertebral column. Dr. Yahya has talked a lot about the spinal cord, and we can see here there is the dentate ligament that attach the spinal cord to the dura, and it's clear in this specimen that we have these small dentate ligament to help stabilize the spinal cord inside the vertebral canal. Here we have the intervertebral foramen. I will not go a lot about it. It's formed by the inferior notch, which is larger than the inferior notch in the pedicle, which is larger than the superior notch in the pedicle below, and the nerve roots named after each vertebra with the nerve roots below it. There is few challenges facing the surgeon when we do thoracic surgery. We take it as a simpler surgery than cervical, but it still has some challenges. The challenges I will talk about is the aorta and the artery of the Adamczyk, the symptomatic chain, Azales Vein, the lungs, and the thoracic duct and superior vena cava, and finally the narrow pedicles. So we can see here in this diagram that the aorta is extending from T3 all down to the T12, and it's in close relation with the spine. This is the cadaver, and we can see that it's very close to the spinal cord, which is about 5 millimeters in most books. This is from a study that they studied the variation in the position of the aorta, mostly in AIS scoliosis. So we can see that the aorta is coming backward and laterally, especially at the apex at T8, T7, it will be very lateral and close to the vertebra, which makes the screws in this side or in the concave side a little bit dangerous to this artery. We can see here that the screw is here, it's touching the aorta. Here, it's almost invading the aorta, and the MRI clearly shows this violation, and it's mostly in scoliosis cases where it goes more lateral and more posterior. This is a diagram or algorithm that the only algorithm that I could find in the literature. It's a level 4 evidence, but it can give a help of an idea of how to manage your screw when you put in the pedicle and it is malpositioned and touching or invading the aorta. I will not go to much details. And then we have the artery of Adam Chbysky. Dr. Shaya also have talked about the blood supply to the spinal cord. The artery of Adam Chbysky is found located normally between T8 and L3. At T9, at T10, about 50%, and it's mostly in the left side in 75% of cases. The importance of Adam Chbysky artery is when we do anterior exposure to the spine, either for instrumentation or for reconstruction or for tumor removal. It could be mistaken as an intercostal nerve. We can see here that it looks like the other intercostal nerves, but it gives a lot of supply to the spinal cord, and the injury to Adam Chbysky could lead to a paralysis. This is another highlight on the position of the neurovascular bundle in the lower edge of the ribs, which is important when we do anterior approach to the spine. That when we need to resect the rib, we have to take careful dissection not to injure this neurovascular bundle. The other vascular nearby the spine is the Azales vein. We can see here clearly it lies immediately above, immediately in front of the spine. In AIS, it's have been reported that there is injury with long pedicle screws, and during vertebroplasty, the venous drainage of the vertebra is drained to the Azales vein, and this could lead to pulmonary embolism. The lungs, they are important. They are a big organ, and we can avoid it. During the posterior approach, like in VCR, we need to take care not to injure the pleura, and if we do, we have to put the thoracic tube before we finish the surgery. And from the anterior, with the help of the anesthesia, we can do selective intubation that deflate the lungs in the side of approach. This is the thoracic duct. We can see it also lie in front of the spine. It will be between the Azales vein and the aorta. And there is a lot of variation in the position and on the number of ducts has been reported in the literature. We can see clearly that it comes from T3 to up to L2, but it could be one or it could be two in each side. The other tissue is the sympathetic chain. We can see here, this is part of the sympathetic chain, which extend from in the posterolateral side of the thoracic spine from T1 to T9. The pedicle diameter, it's most important in our surgeries, as most of the spine surgery, of the thoracic spine surgery, is posterior approach, and the positioning of the screws is very important, as the canal is very narrow, the pedicle is very narrow, and the aorta is not far from the spine. So the pedicle wall is twice thick medially as laterally. The T4 has the narrowest pedicle on average. The T7 be regular and have narrow diameter on the concave side in AIS. The T12 usually has the larger pedicle diameter than L1. The pedicle length, as we see in this diagram, it decreases from T1 to T4 and then increases again until we reach the T12. The T1 is 20 millimeter, the T4 is 14, and then the T10 is 20 again. The pedicle angle is changed also from the T1 to T9, and the transverse angle varies from 10 degrees in the mid-thoracic to 30 degrees when we go down to the lumbar area. The sagittal pedicle is around 15 to 70 degrees cephalid and the majority of the thoracic vertebrae. This is, as we don't have this year, unfortunately, because of COVID, the cadaveric workshop. I find this a very informative and very detailed article to give you more technical points on how to do the freehand technique in the thoracic area. I will also highlight some point that why the thoracic spine anatomy is important to be understand in anatomical way, and also in how to identify these anatomical vasculature in the MRI or the CT, because approximately 90% of all spine injuries involve the thoracolumbar region from T10 to L2, 50% of which can unstable and lead to neurological deficit, and most of it will need anterior reconstruction. And this is where we have to be aware more about our anatomy. Again, the canal is very narrow, which makes it very vulnerable to compression, either from injury or from tumors. The T12 is a transitional vertebrae between the thoracic and the lumbar area, and it has more chances to be involved in trauma than the other vertebrae. Thank you very much.